today's call. This is the New York City Department of Health and Mental Hygiene's update on COVID-19 for New York City healthcare providers. Our topics today are a COVID-19 healthcare provider update, expanding outpatient practices during COVID-19, and an overview of New York City's TRACE program. As a reminder, a PDF of these slides, as well as a recording of today's webinar, will be available on our website following today's presentation. Please note that you have been placed in listen-only mode. If you have questions during the presentation, please submit them via the Q&A portion of the WebEx, and we will address them as time allows. Here's Dr. Mary Foote.
Hi, thanks, Allie. And hello, everyone. Thank you again for spending part of your Friday afternoon with us. We appreciate your listening. So I'm going to start out with our usual Where Are We Now and give some surveillance and clinical updates from the New York City perspective. And then we have some wonderful special speakers today. Dr. Hannah Helmy will be talking about expanding outpatient practices during COVID-19. And Dr. Neil Bora will be giving us an overview of New York City's TRACE program, which recently kicked off this week. And then we'll hopefully have some good time for questions. So looking at where we are now, the world is still in the midst of its most serious pandemic in the past century, and across the globe, COVID-19 continues to cause serious disruptions and loss of lives, with more than 6.5 million cases and 387,000 deaths. Unfortunately, outbreaks are continuing to accelerate in many parts of the world, especially and including South America, and also parts of the United States, and there's also some increases in transmission in parts of the Middle East in particular. In New York City, fortunately, there does continue to be a decline in case counts, hospitalizations, and deaths. So we can see that prevention measures are working, and we really need to emphasize that they must be maintained as we're transitioning to this new phase of the new stage of the pandemic response. As many of you know, we're going into phase 1 reopening on June 8th. So we still need to be very vigilant and work hard at our efforts to mitigate and suppress. And now we are going to be also implementing the use of contact tracing as well. So this slide represents World Health Organization data looking at cumulative cases and deaths reported to the World Health Organization. And as of now, we are at about 6.5 million cases worldwide and about 390,000 deaths worldwide that have been reported and confirmed. And this slide is just another WHO informational slide looking at a comparison by region in the World Health Organizations. And as you can see, unfortunately, in the Americas, they've really seen a sustained increase in cases, while Europe has been on a decline and somewhat of a plateau. And again, as we were talking about, some of the Arabian Peninsula countries in the Eastern Mediterranean are experiencing another uptick in cases, particularly Iran has been having another wave, and Southeast Asia and the Western Pacific are continuing to see cases, but not in a significant upswing yet. And just of note, there's also with the Asia region, one of the more notable upswing in cases have been largely in India, which continues to have a steep increase in cases. And looking at cumulative cases and deaths in the US, this is our map provided by the New York Times, looking at sort of where are the transmission areas of greatest transmission in cases in the US. And looking as of today, we have over 1.8 million cases in the US. That accounts for about 29% of confirmed global cases. And we are now at, unfortunately, reached the milestone of having over 100,000 deaths here in the US, which accounts for about 28% of reported global deaths. And this is actually a new and interesting map that we wanted to highlight, looking at the change in number of new cases in the US during the past 14 days. So this gives us a better sense of sort of where are the current hotspots starting to develop. And as you can see, the parts in blue represent areas that are having decreases in transmission rates. So fortunately, we are in that category up here in the Northeast. but we do unfortunately see, especially in the southern states, rising transmission, and some of which are kind of in the red danger zone, along with a couple areas in the sort of upper Midwest in Minnesota and Wisconsin. And going into sort of where we are with New York City, but this looking at, fortunately, we are continuing to have in the first top graph a continued decline in cases, and as well as hospitalizations. And this is also looking at our deaths, which have about a 1 to 2 week decline lag behind the case and hospitalizations. So we have seen a very good and steady decline in those as well. I will say that we are watching our surveillance data very closely right now. In almost real time, we get surveillance data from emergency departments and other sources where we're watching very closely, given everything that's been going on recently with mass gatherings and the recent holiday, to make sure that we are detecting very early and watching closely for any signs of uptick in cases. So again, the current status of the outbreak in New York City, and this is as of the 4th, we are at now over 200,000 laboratory confirmed cases with over 55,000 hospitalizations to date. We've had almost 17,000 confirmed deaths and coming up on almost 5,000 probable deaths. So we are over what we think is over 21,000 deaths cumulative in New York City. And this is one of our new really nice visualizations that you can find many more like this on our new data page, given the link at the bottom of the slide. And this in particular image is looking at COVID-19 data by zip code of residents. So you can see we've had deaths. So this is particularly looking at the death rate per 100,000 population and case rate per 100,000 population. As you can see, we have had particular hard hit areas in the Bronx and in Queens, and also a little bit also in Staten Island. So those are some of kind of the big hotspots that have been really impacted. And this is looking at COVID-19 death, and these are rates per 100,000 people again, according to age group at the top, race and ethnicity in the middle, and the bottom figure is showing deaths by neighborhood poverty level. So as you can see, for age groups 75 and over, but also 65 to 74 have been particularly impacted in terms of rate, but also in the age group of 45 to 64 have also, had significant death rates as well compared to the younger age groups. And in terms of race, ethnicity, unfortunately, our Latinx population has been most heavily impacted, very closely followed by Black and African American New Yorkers have had a significantly higher rate of death compared to white and Asian Pacific Islander New Yorkers. And again, this is probably, unfortunately, not surprising to anybody, but neighborhoods that have been shown to have very high poverty rates and high poverty rates have unfortunately been disproportionately impacted by the effects of COVID as well. And this is looking at this is another figure looking at our daily testing for COVID-19 over time. And the figure on the left, the dark blue line, shows the increasing number of people being tested, and the light blue line shows the decreasing number of people who are testing positive of those that were tested. And then this figure on the right uses the same data to show the decreasing percent of people tested with a positive result. So again, we are having a steady decline, and steady increase in testing that's being done, which is also showing us a lower percentage of positivity as we test more people and have declining rates of transmission. And then finally, I just wanted to end with a couple of updates again about multi-system inflammatory syndrome in children, or MIS-C, and just provide a reminder to all of you to report all cases, all suspected cases, to the New York City Health Department by calling our provider access line, and you'll see the number there. And we really want to make sure that you are reporting regardless of laboratory evidence of SARS-CoV-2 infection, based on our clinical case definition that we'll go over next. And consider MIS-C in any pediatric death with evidence of SARS-CoV-2 infection. And the New York City Health Department, we are investigating all reports. And just as a update in the numbers, as of June 4th, we have had 232 reports that have been received by the New York City Health Department. Of those, 141 have met the CDC case definition for MIS-C. 44 of those reported did not meet the case definition, and 47 are still under investigation. And overall, we are still at, fortunately, just one death reported. And just to review our reporting requirements, we are now aligned with New York State reporting requirements. So we request that you report any individual aged less than 21 years who meet the following clinical and general laboratory criteria and does not have an alternate diagnosis. So the clinical criteria include, and all three of these have to be met, which is 1 or more day of subjective or measured fevers, hospitalized patient, and either 1 or more of the following are found, which would be hypotension or shock, features of severe cardiac illness, or evidence of other severe end organ involvement, including severe respiratory disease alone. Or we are also including those that have 1 or 2 or more of the following symptoms, which include, or signs, which include maculopapular rash, bilateral non-purulent conjunctivitis, mucocutaneous inflammatory signs of the hands, mouth, or feet, or acute gastrointestinal symptoms, including such as diarrhea, vomiting, or abdominal pain. And the general laboratory criteria that have to also be met include at least 2 markers of inflammation, which include, for example, neutrophilia, lymphopenia, or elevated CRP. So those are just a review of what we would like you to report to us, please. And I am now, again, thank you all for being here with us, and I'm going to turn it over to my esteemed colleague, Dr. Hannah Helmy, to talk about reopening and expanding outpatient practices. Thank you.
Great, thank you, Dr. Foote. Good afternoon, everyone. My name is Hannah Helmy, and I'm a special advisor for the Health Systems Planning and Strategies Group here at the New York City Health Department. And as Mary mentioned, I'll be sharing some considerations and resources for expanding outpatient practices. So first, I'll share some data on what we know about COVID-19 inequities in New York City, and some national data on the effects of COVID-19 on health and household economic stability before discussing the impact of COVID-19 on outpatient practices. Then I'll review some key considerations for expanding outpatient practice with a spotlight on optimizing patient care. Next slide, please. So the next few slides will display maps from the Primary Care Development Corporation, which use DOHMH data to examine the distribution of COVID-19 cases in the city through May 4th, and its associations with sociodemographic factors, chronic disease conditions, and primary care access. On this slide, the map on the left displays the rate of COVID-19 cases by zip code, reflecting that many communities are disproportionately impacted, as Dr. Foote's presentation also demonstrated. When we look at the percent of low-income residents and percent of Black residents by zip code, we see that these neighborhoods have higher COVID-19 rates. Additional DOHMH data on mortality that you just saw also demonstrate disproportionate impacts on Black and Latinx New Yorkers as compared to white and Asian New Yorkers. So the way that COVID-19 is distributed across the city reflects the inequitable availability of health promoting resources and opportunities resulting from systemic racism. Next slide, please. On this slide, we see maps comparing, again, the rate of COVID-19 by zip code and the percentage of residents with diabetes and hypertension by zip code. COVID-19 rates are highest in neighborhoods with the highest levels of chronic disease burden, which often result from environmental factors such as food deserts and poor air quality. Next slide. And lastly, we see that many neighborhoods with less access to primary care services are also those experiencing higher rates of COVID-19. So taken together, these data suggest that particular neighborhoods are bearing a disproportionate brunt of COVID-19 mortality and morbidity, and often have less access to primary care as a result of structural and environmental factors. Next, shifting gears a bit, I wanted to provide some data, this time from a recent Kaiser Family Foundation national poll illuminating the impact of COVID-19 on healthcare seeking. So in this poll, about half of respondents indicated that they or a family member in their household had skipped or postponed medical care because of the COVID-19 pandemic over the past 3 months. And of that, half, 11%, reported the condition worsening. While these data are national, we know that delayed or foregone care has been widespread in New York City as well. Next slide, please. From this same poll, we see that 40% reported that stress and worry from coronavirus has had a negative impact on the respondents' mental health. And on this slide, we see that a substantial percentage of respondents report that since February, they or any other adult in their household had experienced difficulties paying for household expenses, such as bills, utilities, and rent since February. On this slide, we see that 1 in 6 respondents reported skipping a meal, visiting a food bank, or applying for or receiving SNAP benefits since February as a result of the coronavirus. And lastly, looking at how these challenges are playing out inequitably for various sociodemographic groups. Larger proportions of Black, Latinx, and lower income households report skipping meals, relying on charity or government food programs. So again, the picture from these data is that COVID-19 has resulted in delaying or deferring medical care, negatively impacting mental health, and has resulted in greater economic instability and food insecurity, which is disproportionately impacting Black, Latinx, and lower income households. So next, thinking about what the effects of COVID-19 have been on the health system, which are numerous, and in particular, outpatient care. So there's been so many headlines and articles published about the operational, staffing, supply, and financial challenges facing clinics. These impacts are certainly not exhaustive, what you see on the slide, but include having a significant decrease in visits. A recent survey of New York City independent practices and New York State FQHCs showed that visits have decreased by up to 50% since early March, resulting in a significant impact on revenue. We know that clinics are experiencing staff shortages and furloughs with a disproportionate impact on smaller clinics, as well as major challenges with procuring and maintaining stock of PPE and other supplies, and challenges with telehealth implementation. So numerous challenges facing patients, major impacts on outpatient practices as we're entering a period where we're seeing fewer cases, hospitalizations, and deaths, and facilities are starting to reopen or expand their services. So in preparation for that transition, we've put together some high-level considerations for how outpatient practices can expand care provision while prioritizing certain patients. And these are from a larger, more comprehensive guide for resuming or expanding services for outpatient settings, which we hope to share with you on our provider page very soon. So first, staying up to date with the latest information and guidance on COVID-19 from city, state, and federal, and being familiar with guidelines from your specialty on reopening or expanding services. Maintaining or resuming preventive care, such as delayed or due childhood immunizations and care for chronic conditions. Weighing the risks and benefits to your patients of coming in for services. So for example, thinking about the risk benefit of having patients come in knowing that they may be relying on public transportation and what the transmission risks of that might be. Continue to use telemedicine for appropriate visits as you expand in-person visits, and leveraging health technology to improve care. And on last week's webinar, I believe there were some great New York City Reach tools that were shared, so that would be a good place to look. Other high-level considerations are keeping patients and staff educated and updated as information changes. So much is being updated and revised in this time. So making sure that that your patients coming in are aware of how to prepare for in-person visits, what safety precautions your facility has put in place in response to COVID-19, updating staff on new clinical guidance, infection control, and administrative policies, having adequate supplies on hand, PPE, disinfectant, hand hygiene, other kinds of supplies. Not going to be focusing on PPE today, but I did want to highlight two things. In addition to universal masking in facilities, we are also going to be recommending that providers wear eye protection in all encounters. So that's something to take into account in PPE stockpiles. And second, there's a new PPE and medical supply company one-pager from the health department that is included in the resources slides at the end of the presentation. Another consideration is optimizing infection control, triage, and physical distancing practices. So for more information on that, we've got some great resources on the provider page. There's a webinar that was done on 5/15 and the health department's outpatient infection control quick guide. And lastly, supporting the health and well-being of your staff and planning for staff shortages that may occur. Second to last. Last is being prepared for psychosocial and socioeconomic challenges that are facing both your patients and staff, which we'll talk about in a little more detail soon. So expanding on some of those high-level considerations, last week the health department issued HAN number 17, which focused on advising patients when to seek essential care and plan to expand in-person patient services. So I want to highlight some of that guidance. So first, we know that many folks have been delaying seeking urgent care. So we're urging patients with severe symptoms due to any health condition to seek medical care promptly, either by calling 911 or going to the nearest emergency room. And those symptoms include trouble breathing, signs of possible stroke or heart attack, and newly altered mental status. And we're also advising that parents and caregivers be educated about how to recognize and seek prompt care for symptoms of MIS-C. Second, the HAN provides guidance on prioritizing essential medical care, patients at higher risk for poor health outcomes, and patients who can't access telemedicine as in-person services are expanded. It recommends a number of groups and services for which visits should be prioritized. So here are some examples organized into 4 broad categories. This is not an exhaustive list. So urgent visits would be one category, such as those for sick visits requiring diagnostic testing, chronic disease management visits, such as for those who cannot access telehealth, maternal and child health visits, such as vaccinations for children up to 24 months who are due or overdue for immunizations. As I know everyone knows, this is a big one, as the recent MMWR on the drop in childhood vaccines demonstrated. And lastly, those for which privacy is a significant concern, such as patients with a history of intimate partner violence who may not be able to safely access telehealth services. Okay, and the third bit of guidance from the recent HAN was to encourage patients who are not at increased risk of complications from COVID-19 to donate blood, given the severe blood shortages in the city and nationally. Okay, so next I'll focus on a few approaches to optimize patient care. Telehealth remains an important modality for access as in-person visits are expanded, but we know it has not been without its challenges. To optimize telehealth access, some things to consider, particularly for patients who will need additional help setting up telehealth on their device, and for those who don't have a telephone, video capability, or internet access. So some things you can do to help your patients in those situations. Think about accommodating audio-only visits, so telephonic services and virtual check-ins. Refer patients to services that can help income-eligible New Yorkers obtain an inexpensive phone line or mobile phone. Assign staff to provide extra support and training to patients who are not comfortable with technology. Plan longer visit times for patients who are not used to using virtual technology and for patients with cognitive or physical impairments. And ask patients if they have a family member or caregiver who can help facilitate the telehealth appointment. In supporting patients who may normally come to your office for chronic disease management but are having trouble getting to your facility or prefer telehealth visits, you can consider, whether your patient has the necessary equipment to monitor their health at home, such as a blood pressure monitor, a glucose monitor. And you can support patients' access to these supplies through their private insurance plan, Medicaid, or Medicare if eligible, as well as providing written instructions on proper use of equipment and provide additional support if needed. Okay, so next, addressing psychosocial and socioeconomic challenges during COVID-19. Many of these considerations may already be happening at your facility, which is fantastic, but want to underscore how important it is to proactively support patients experiencing a myriad of compounded and new challenges during the pandemic, and think about ways we can do that leveraging available resources. It's also important to note that your staff may also be experiencing issues with depression, anxiety, and economic stability. So some of these resources will be applicable for them as well. So first is to provide information to eligible patients. This is also available to healthcare workers about the city's COVID-19 hoteling program for those who need to isolate from household members but can't socially distance in their setting. We also are encouraging employing trauma and resilience-informed approaches with patients who may be experiencing direct complications from COVID-19, but also trauma and psychosocial stressors resulting from the loss of loved ones, unemployment, domestic violence, and other issues. So we have a couple of resources. Those are available at the end of the slide deck on our website. So the resource on COVID-19 coping and emotional well-being. There's also a recent Dear Colleague letter in the resources slides, which provides guidance on recognizing and addressing behavioral health concerns during COVID-19. You might want to consider routine mental health screenings for patients at higher risk for severe illness, stress, and depression due to COVID-19. And consider how you can better integrate social, mental health, and medical services in your practice, including screening and providing referrals and resources for things like substance use disorders, domestic and interpersonal violence, isolation, especially in elderly populations, and social determinants of health, including food insecurity. You may want to consider using a structural vulnerability screening and assessment tool like the one described by Bourgois and colleagues, which helps identify patients who may benefit from multidisciplinary and social services outside of your clinic. And the screening questions in that tool include things like financial security, place of residence, risk environments, food access, social networks, and so on. I also want to highlight some resources such as the New York City Access to determine eligibility for various benefits and the COVID-19 resources by neighborhood guide, which include neighborhood snapshots with groceries and pharmacies that deliver and social service organizations in neighborhoods hard hit by COVID-19. Those are both also at the end of the presentation. You may also want to consider using your electronic health record to help you respond to psychosocial issues and needs. So for example, using or building templates and structured fields for screenings and incorporating that screening information into telehealth workflows. Consider engaging patients in advanced directive conversations, perhaps sooner than you might otherwise due to the possibility of severe COVID-19 illness. And lastly, maintain a list of culturally and linguistically appropriate behavioral health resources and social services to share with your patients. And finally, some reminders on optimizing care through patient-centered communication. As we've discussed, many New Yorkers are experiencing new or exacerbated challenges with a range of issues, such as housing instability, economic and food insecurity, and grief. I've included links for 2 great resources at the bottom of this slide, so please check those out. And here I will just briefly highlight considerations for communicating effectively with your patients about difficult topics, which include preparing to talk by considering your own feelings and fears about COVID-19 and recognizing that they may not be the same as your patients. Being sure to sufficiently review the chart, including social and familial situation, job situation, mental health history, and so on, to inform your conversation. This information may help you anticipate challenges that they could be facing right now. Engage using open-ended questions like, what are you most concerned about right now? And use reflective listening skills, paying attention to behaviors that might signal that the patient is uncomfortable or doesn't feel safe. Responding honestly to their questions and concerns and acknowledging that there are real uncertainties, as well as offering additional information and resources. I'll also just mention briefly that given the fact that there are ongoing protests against police violence and structural racism, and you may have patients that come in to see you that have been impacted physically or psychologically or both, we encourage you to think about the ways to engage and support your patients in trauma-informed approaches. So the CAPC link on this slide has some good resources and scripts, including how to name and talk about structural racism with your patients, which is always timely, but feels especially important to highlight. And you may also want to provide patients with harm reduction strategies while they exercise their rights to protest, such as wearing a face covering and protective eyewear, bringing hand sanitizer, staying hydrated, using signs and noisemakers instead of yelling, sticking to small groups, and trying to keep 6 feet apart from other groups. And also for patients who participate in protests, you may want to advise them to consider testing and take steps to protect vulnerable family members from in the 2 weeks after participating in the mass gathering. Okay, so to close, I want to emphasize a few points returning to the data shared earlier in the presentation. First, delaying and missing care may be creating new health crises, so be proactive in reaching out to your patients who need care. Second, we know that COVID-19 is deepening existing health and socioeconomic inequities. How can these impacts be reduced for the most vulnerable? And likewise, what are existing and novel ways that we can better address social determinants to improve patients' health and resiliency? Lastly, it's critical to center equity principles as services are expanded. And those are the resources on this slide and the next one, many of which I covered during the presentation, but some additional ones there as well. Thank you.
Hi, thank you very much. My name is Neil. I'm one of the physicians at the health department, and I'm also with New York City Health and Hospitals, and I have the great privilege of being a part of the TRACE program. And today I'm going to be giving you an overview of the TRACE program because we launched it this week. The overarching goal for TRACE is to suppress COVID-19 through interrupting chains of transmission. So we're trying to stop COVID through doing case investigations and contact tracing. And we're going to be doing this at an unprecedented scale in recent history. Contact tracing is a very robust and often used tool in public health, used for outbreaks, including for Ebola and previously smallpox. And in recent history, though, particularly in the United States, an effort to undertake contact tracing at the scale that is required right now has not been done. Last effort that I can think of on the scale that we're talking about right now is from the late 70s for smallpox. My dad actually had smallpox when he was a kid, and so this is something that's very meaningful for me because, at least in the case of smallpox, contact tracing was such a huge part of the effort to control that terrible disease. And our goals are slightly different, you know, whether for COVID in terms of what the outcome for contact tracing can be and goals about eradication, because smallpox is a very different disease. But still, it's the same idea that we need to find cases, we need to find the people around cases who were exposed so that we can appropriately care for those exposed individuals as well as the cases themselves. And this is, in my view, just such a tremendous opportunity to do something impactful that we can do as a partnership, because all New Yorkers need to get involved to do this work at a time when the world has really not depended on public health this much in many, many decades, if ever. And so together, we're going to be able to accomplish this mission because we're all somehow impacted by COVID and contact tracing, either directly or indirectly. Some of you might have seen this diagram before, and this is a view of the phases of the COVID-19 response, starting with preparedness. So this is before there was any COVID at all. And then in December, that's when, December 2019, that's when the first cases started to emerge. And that's when the containment strategy was used to basically address clusters of cases. And as transmission increased beyond a certain level, there was the recognition that there's local and even widespread transmission. And so that was the move into the mitigation strategy. And now we're in a period of declining transmission. So this is the suppression phase. And to maintain us in that suppression phase is where contact tracing becomes so important. So I'll say that New Yorkers have done such an amazing job with socially distancing over the last 2 to 3 months. And the results of all of those efforts have been that daily case counts are decreasing, as you saw on earlier slides in this presentation. And to help us stay at this lower level of transmission requires that we now use new approaches, particularly around case investigation and contact tracing, coupled with the greater, much greater access to testing that is now available across New York City. Some basic terms. So a case is anyone with a laboratory confirmed positive COVID-19 test result. And particularly we're talking about a diagnostic test looking for genetic materials, also an antigen-based test, but we're not talking about an antibody test for that laboratory confirmed diagnosis. Also, there are probable cases, which refers to people who are contacts of a COVID-19 case who have symptoms of COVID-19, but not yet themselves have had a test for COVID. Of course, if such a probable case were to get tested for COVID and the result were positive, then we would consider the person a confirmed case. There's also contacts, and there's 4 different categories of contacts. There are household members, there are intimate partners, and so that includes people that a case might have kissed or had sex with. There are individuals who are providing care in the household of the case. And then there are individuals who spend 10 or more minutes within 6 feet of a person known to have COVID-19. So individuals who spend 10 or more minutes within 6 feet of a case. And that's regardless of whether that contact is wearing a face covering or not. And the reason for that is because we can't always be sure how well a member of the general public is using that face covering. Oftentimes we see people wearing a face covering but not covering their nose. Or they're wearing a face covering, but it's actually hanging below their nose and mouth. And so that's part of the reason why we do not consider a face covering as part of our decision-making process for determining contacts. I also want to highlight 2 important terms, isolation and quarantine, because sometimes these terms are used interchangeably, but they're not actually meant to be used interchangeably. Isolation specifically refers to the separation of sick people with a contagious disease from people who are not sick. So you're referring to the separation of cases from the rest of the population, whereas quarantine refers to the separation of people who are exposed to a contagious disease to see if they become sick, right? So that is referring to contacts and separating contacts away from the rest of the population to see if they become sick. So I'm specifically involved in the TRACE aspect of New York City's Test and Trace core. So this is the city's new effort to maintain us in the suppression phase. And this requires a 3-pronged approach to stopping COVID-19. First of all, testing, which means that there's a lot more access to testing and making sure that people can get tested to detect infections. There's tracing, which is what I'm talking about with all of you today, which is identifying cases, tracing their contacts, and recommending isolation or quarantine. And then there's taking care of people, right? Because at the end of the day, we're here to save lives and help people. And that's making sure that New Yorkers who are cases or contacts get connected to the resources they need to safely isolate or quarantine, whether at home or in a hotel. So this is just a diagram that can help illustrate why contact tracing and isolation and quarantine have such a big impact. And you see in this scenario, let's say we have a hypothetical disease that has an R0 of 2. So that's the reproductive value. If you've ever seen the movie Contagion, Kate Winslet does a very nice description of R0 in that movie. But this basically means that if you have an R0 of 2, 2 people get infected for every single case, right? So you see that when you start with this single case here, after 1, 2, 3 generations, you're left with, you now have 8 cases of COVID just after 3 generations. If, however, you can break those chains of transmission through, for example, isolation and quarantine, even if you can just get to 50% of the exposed individuals and prevent 50% of the infections, look that even after 3 generations, you now only have 1 case of the disease because you were able to separate out 50% early on in the public health effort. And that's what we're talking about right now with TRACE. We're trying to break chains of transmission. And so we launched this effort on June 1st, so earlier this week. Most of our work is done remotely because we are, of course, worried about the health and safety of our staff. TRACE will evolve with the outbreak. Just like the outbreak, just like since February, even before that, our response to COVID has evolved as the scenario has changed. Same thing with TRACE. We have to be willing to adapt our tasks and our protocols depending on what the data show. And that's why we need continued input, particularly from all of you and the provider community based on what you're seeing. We also have to acknowledge that we're not going to be perfect. This is, a disease like COVID is very different than a disease like Ebola. For a disease like Ebola, you have a much greater likelihood of being able to find every case. And that's largely because of the mode of transmission for a disease like Ebola, but also because we don't really know of instances of asymptomatic transmission or pre-symptomatic transmission of Ebola. In contrast, COVID is spread through the droplet route. There's asymptomatic and pre-symptomatic transmission, and these all add to the challenges. And it means that we're not going to be perfect when it comes to COVID, but even if we're not perfect, we can have a huge impact on suppressing COVID in New York City, as was shown on the prior 2 slides with that diagram. So we identify cases through robust surveillance mechanisms that already exist in New York City. All COVID-19 tests performed in a laboratory are automatically reported to the New York City Health Department. And every new laboratory confirmed case in a New York City resident is therefore automatically enrolled into the TRACE program. And this also means that because we're already hearing about reported cases through the health department, getting reports about cases from the public are potentially supplemental, but are not critical at this time. So what I mean, again, is that we are already getting, we already learned about every case through existing surveillance mechanisms for laboratory reportable diseases. And so we hear about every COVID case for which laboratory testing was done and the result was positive. And so if the public reports to us as well, it's supplemental, but it's not critical at this time. We then identify context because we interview these cases that we hear about, and we ask them about their close contacts. And I described before what are the 4 different criteria for what constitutes a close contact. And we ask the case to name their close contact and give us the contact information. And then we follow up with those close contacts and we interview them. So basically, all of these close contacts are enrolled into the TRACE program. And one thing that's going to happen, like I mentioned before, it's not going to be possible to find every contact in New York City. But the good news is that with more access to testing, people who believe they were exposed but they've not yet been contacted by the TRACE program should consider getting tested and undergoing self-quarantine for themselves. If you're worried about an exposure or you're worried about an exposure in your patients and they have not been contacted by the TRACE program, you can still proceed to get them tested and recommend that they self-quarantine while they're awaiting their results. And of course, if they turn out to be positive, like I said before, we'll automatically hear about them and we'll then enroll them automatically into the TRACE program. I'm going to try to move quickly to make sure that we have enough time for questions. So we have 4 different roles in the program. We have investigators who do the initial case investigation. We have the monitors, because once we hear about a case or a contact, beyond the initial case investigation or the initial notification to the contact, we then follow the cases and the contacts for 10 to 14 days so that we can check up on their health status every day and see if they have any other needs, because we check in on every person if they need help with hoteling, if they need help with food, if they need other supplies that are essential. We can help them during their isolation and quarantine period. We also have other roles, and I want to highlight the bottom one, which is for community engagement. Actually, I'm going to highlight both of these. So the information gatherer, this is a very important role because we hear about these cases automatically, but quite often, in around 20% of the cases, we actually do not get any phone number when we hear about that case, which becomes problematic, because then we can't reach out to the person via phone, which is ideal. It's efficient and it's safe. That's the safest way to reach out to these cases. And so that's where our information gatherer comes in, and they're going to use various resources to try to find additional contact information on these cases and contacts who come in without good phone numbers or without any phone number at all. So a warning for all of you, a friendly reminder to all of you, is that you might hear from people on the TRACE team. You might get called as a provider, and we might ask you, hey, such and such patient was actually tested by you on June 2nd and had a positive result, but we don't have a good phone number. Can you give us the phone number? Because we know who the ordering provider is for these cases. And so that's why we might call you up through our information gatherer. Also, we have staff who might go into the community and actually knock on cases and contacts doors. If they're not answering their phone, we want to make sure that we check in on them to ensure that people are getting the services that they need. And so we have a community engagement team as well. So we educate every case about their diagnosis. When we learn of them, we monitor them daily. We identify their contacts. We recommend and support their isolation. We evaluate their need for supportive services, and we inform them when they can end isolation. We also, for contacts, similarly, educate contacts about their COVID-19 exposure. We monitor them daily for new or worsening illness. We recommend and support quarantine. We evaluate their need for supportive services, and we inform them when they can end their quarantine. So this is just a diagram of what we do when we enroll people into the program. We confirm their identity. If there's a case, so we confirm their identity. We collect demographic information. It's important to get that information on them about how they identify their race, their ethnicity, their sexual orientation, their gender identity, because these will allow us, with these data, we can find whether there are pockets of New Yorkers who are disproportionately impacted by COVID, which we know that is already the case. But the more data we have on this, the better we can target our interventions. We then confirm that the case resides in New York City. We assess their symptoms. We identify their contacts. We recommend isolation. We assess need for supportive services. We ask them for how they want to be monitored, whether it be a phone or text messages. We enroll them in daily monitoring, and then we complete the interview. Just so you know, right now we have not yet enabled the text messaging capability, but that will come in the future. We have a similar flow for contacts. In the interest of time, I'm not going to go through this in detail. But I want to provide some general information for COVID-19 testing. When you test your patients for COVID-19, let them know that they're going to be enrolled in the TRACE program if they test positive. People are rightfully concerned about the security of their information. People are skeptical of programs such as TRACE, but we're here to help people stay safe in New York City if they get diagnosed with COVID or they get exposed. And we're here to try to break chains of transmission. And so please, when you test your patients for COVID, let them know that if they test positive, they should expect to receive a phone call from the TRACE program. Please also always collect good phone numbers and addresses on your patients, because if we don't have this information, we cannot investigate the cases. And if a patient thinks that they were exposed to COVID-19, but they don't get called by the TRACE program, you can still test your patient for COVID-19. And if they test positive, we'll enroll them into the program. So I want to just go through what we commit to do. We're going to be using a trauma-informed approach that builds trust and facilitates sharing. The last 3 months and more have been traumatizing for many, many New Yorkers, and for really understandable reasons. This has been scary. Our lives have been infected. Our economic stability has been affected. We've lost family members. We've lost friends and loved ones. It's been a really difficult 3 months. And so that's why it's very important that we use a trauma-informed approach. We are here, we cannot do our work without maintaining trust, and that means protecting and maintaining privacy and confidentiality. We are going to communicate in a clear, professional, and compassionate manner. We are going to ensure that our engagements with our clients, meaning our cases and contacts, are respectful and informed by cultural humility, gender identity and expression awareness, and an understanding of health inequities. We're going to ensure services are provided for all New Yorkers, regardless of immigration status, language, or identity. We're going to promote safe and equitable practices for our staff. And we're going to understand and support populations who may be at higher risk for COVID-19 and its complications. So we're going to move on to questions now, but I want to emphasize again that this is a team effort, not just within the actual TRACE team, but between all of us. Every New Yorker is somehow involved in the TRACE program, either directly or indirectly, and we hope that we can work together. And New Yorkers, like I said before, have done such an amazing job in social distancing, in physical distancing, and that those efforts have brought down the daily case count. And to keep us there, we really need to have a program where we can do case investigations and contact tracing, because that will allow us to break those chains of transmission. We're not going to be perfect, but what I can promise you is that we're going to commit to always doing a better job and improving over time. And hopefully we're going to get better and better over time then, so that we can continue to serve New Yorkers the best way possible.
Thank you, Neil, and to Dr. Foote and to Dr. Helmy for your great presentations. We have a few minutes left for questions. Just want to point out that some of these links that you see on the screen in front of you, especially the one at the top there, is a link to our provider page where you will be able to find slides and recordings for this webinar, as well as all of our previous webinars.
Allison, should I ask a couple questions?
Yes, thank you.
All right, we've pulled a couple of questions from the Q&A. Dr. Vora, we have a few questions around contact tracing. The first question is, what are we going to do about isolation or quarantine for people who have, for isolation or quarantine for contacts, and especially for specific populations such as youth in detentions or residential facilities that have limited extra space?
These are really important. This is a really important point. So every case needs to get isolated. And for contacts, there are certain categories of people who, even if you're a contact, you might not need to get quarantined because you fall into an essential worker category, such as many of you on the phone who are healthcare personnel yourselves. And so, these are among the considerations that have to go into effect. But there's also special categories of people who are especially vulnerable. And that's why we offer hoteling services for cases and contacts, so that if certain people do not have the safest conditions for isolation and quarantine, they can go to a hotel. And if they are unable to go to a hotel because, for example, they have family members that they have to care for at home, in those instances, we can also support them in their homes by providing necessary resources. But congregate settings in particular pose a special challenge because there are so many vulnerable people in a confined space, and that's an area that we're going to have to continue to look at. It's been an area of challenge in the last several months. It's going to continue to pose challenges, but we have to continually evaluate and recognize that there are vulnerable populations in these congregate settings and make sure that we appropriately provide resources so that they can do what's needed from a public health perspective.
Thanks, Dr. Vora. And then another one for you. We've had a couple questions talking about, trust in government operations and fears that persons who are contacted by the TRACE program may have about, what's being done with their information about, immigration status, about, their sexual partners, etc.
This is a concern that I share as well. People are right to be concerned because we live in a world where data is obviously really valuable, and we hear all the time about large companies with violations and breaches in confidentiality. We take confidentiality of utmost, that is one of our top priorities because we can't do our work without maintaining data security. And so we promise to do our very best to continue to maintain that security of the data, and we're going to protect the data to the fullest extent of the law. We are not here, we're not a law enforcement agency, we are a public health and health operation, and so we already routinely have experiences of dealing with communicable diseases and providing care to the H&H system, including for people who who are undocumented or have other concerns about their interactions with law enforcement and other aspects of other government agencies and how their data will be protected. And so we come in with that level of experience, and we're going to continue to prioritize data security and confidentiality in all of the work that we do. It would help, I'll just add though, that you all as providers, when you're testing your patients, to let them know about the TRACE program, because if you inform them, they can expect the call and they would be more willing to engage with the TRACE program as we do the contact tracing efforts. And this is good for both that individual and also for New York City as a whole. It's good for the individual because we're then able to monitor the person on a daily basis. During the last 3 months, we sadly observed many people dying in their home. And part of that was because they had sudden onset of respiratory failure, for example. There's that concept of silent hypoxemia where people were chugging along, not really realizing that they were hypoxemic, and then they suddenly, unfortunately, crashed. And so we monitor people on a daily basis, and we can connect them to care if needed. But also we can provide them with services that they might need, like food. And then also the public health imperative is that we can break chains of transmission if we all work together.
Thank you so much. And then I think we only have 2 minutes left, but very quickly, there are a couple questions about the information from monitoring and testing that will be done by the TRACE program and how that will get back to providers.
So like I said before, the program's going to evolve over time. We're not going to get it perfect at first. We're going to also add in more and more nuances to our protocols over time. So I would say that right now, the plan is just generally speaking, we identify cases through existing surveillance mechanisms. We interview them, we find out who their contacts are, then we follow up with the contacts. Right now, we're not closing the loop with the provider that we're monitoring their patient or anything like that. In the future, our protocols might evolve, but again, for now, we're not going to be reaching out to the providers just to let them know that we are monitoring their patients for any COVID-related reason.
All right, thank you. And then actually, you know what, maybe in our last 1 minute, we'll have Dr. Helmy just talk a little bit about resources available for patients to get internet access to engage in telemedicine.
Sure. So I think I shared, there's a couple of links. Not sure if they made their way into that part of the chat. So there's a federal program for discounted phone service, which can have internet on it. And then there is a government-supported service called SafeLink Wireless that provides cell phones to income-eligible New Yorkers. I will look into if someone is looking for internet access not through a phone, through a smartphone, I will look into that and get back to you.
Okay, and I think I think that the participants who are interested can look for the links that Dr. Helmy posted in the chat box.
Okay, they are there. Great.
Okay, thank you. And thank you to Dr. Ray for joining us for the Q&A portion. Much appreciated. And to all of you for answering those questions, as well as sharing the information in your presentations today. We just listed some of the links that you'll see at the end of Dr. Helmy's presentation here, and thank you for posting those links in the chat. As a reminder, the slides and recording will be available on our website as soon as possible. We thank you for joining us, and we hope that you will join us next week at 2 p.m. Have a good afternoon.